Here we present a case of rapidly progressive aortic root abscess complicated by Gerbode defect. Damaged heart valves or prosthetic heart valves are some common spots for bacteria in the blood to attach. One situation in which this becomes dangerous and complex is when the infection erodes the membranous septum in the heart. The membranous septum separates the right atrium from the left ventricle. When this breaks down, it is called a Gerbode defect. This defect was initially discovered as a congenital anomaly, and it can also be acquired. We present a case here of an acquired Gerbode defect in a prosthetic heart valve due to infective endocarditis.
Our patient is a 51-year-old male with a history of polysubstance use and prior methicillin-susceptible Staphylococcus aureus endocarditis resulting in an aortic valve replacement with bioprosthetic valve. The patient initially presented to another hospital and was diagnosed with MSSA bacteremia. He was treated and discharged home with dalbavancin for 4 weeks. TEE at that time was negative for abscess or vegetation, which you can see next to day 1 on our poster. 3 days after being discharged, on day 4, he represented to the outside hospital with new neurologic deficits. Imaging showed infarct spread across the brain, lungs, and spleen, concerning for septic emboli. TEE was performed again and did not show any vegetations or abscesses. However, per due major criteria, this patient met the definition for infective endocarditis at that time.
On day 8, he was transferred to our center where TEE showed a large aortic root abscess that eroded through the membranous septum, causing a Gerbode defect. EKG at this time showed sinus tachycardia with no significant conduction abnormalities. Given the multifocal embolic strokes, discussions on optimal timing for open heart surgery were had with neurology given the need for anticoagulation and possible hemorrhagic conversion. On day 11, the patient had an acute decompensation with new conduction abnormalities, including first-degree AV block with a PR interval of 180 milliseconds and right bundle branch block on EKG. He became severely tachypnic, requiring intubation. Following intubation, the patient became pulseless. ACLS was started with ROSC after 2 rounds, and the patient was quickly moved to the cardiac ICU. He developed PEA again, requiring ACLS with ROSC. Emergent TTE was performed showing a rocking aortic valve. Then emergent TEE was then performed, which showed complete dehiscence of the septum and a loosely attached prosthetic aortic valve with free flow between the aorta and left ventricle and right atrium. We will show you both of these echocardiograms on the upcoming slide. Further resuscitation was then deemed futile by the cardiac team, and the patient expired quickly after withdrawal of care.
As we've discussed, this patient had multiple factors making him high risk for endocarditis, including IV drug use and prosthetic aortic valve replacement. MSSA is notorious for the rapid progression of infection, which was evident in this case. The infection developed from something not visible on TEE to a large abscess eroding through the membranous septum. A couple of key points to take away from this case are the importance of knowing the likelihood of endocarditis in a patient and treating appropriately. Using the Duke criteria can be a valuable tool. The dalbavancin that this patient was discharged on is not an FDA-approved treatment for endocarditis, and he was likely discharged on this due to the negative TEE. However, in this patient who is extremely high risk for endocarditis with known MSSA bacteremia, treating with standard of care would have been the correct course of action.
Gerbode defects are rare but interesting cases to examine the anatomy and physiologic effects of creating an LVRA shunt. Most people think the ventricular septum as separating the left ventricle from the right ventricle. However, this case highlights the fact that the septum extends beyond the tricuspid valve into the right atrium, and the wall there is a thin membrane. If this septum is broken down or not present at birth, a shunt is created between the high pressure left ventricle and the low pressure right atrium. The number of prosthetic heart valves is increasing yearly, and in turn increasing the risk for those patients with prosthetic valves to get infective endocarditis and develop medical emergencies. It is important for the general internist to be aware of the risks inherent in prosthetic valves and manage patients with infective endocarditis appropriately.
This video shows the loose prosthetic aortic valve shown on TTE after the patient's acute decompensation, pointed out with the green arrow. This video shows the Gerbode defect in our patient, with the red arrow highlighting the flow going from the left ventricle on the right side of your screen to the right atrium on the left side of your screen, the green arrow pointing to the aortic root abscess, and the yellow arrow pointing to the vegetation.